This is a discussion about aortic diseases. We're going to be talking about first aortic aneurysms. So if you remember, the aorta is the main big vein coming from the left ventricle and going into the body, providing all the body with circulation. It has three branches on the arch of the aorta that comes up like this, actually like this, over like this, and it has these three branches, and that provides the head and the arms. And then it goes down into the abdomen. There's a thoracic aorta and the abdominal aorta, and it throws off all kinds of branches and supplies the whole body with blood. So an aortic aneurysm is where somewhere on this major blood vessel you have a bulge where normally, it's going to have this kind of fairly even diameter as it goes down, it'll be decreasing slightly as it goes further. But with an aneurysm, there's a bulge, and it can be a saccular aneurysm, which is a circumferential bulge all the way around, or it can be, it can be a fusiform aneurysm, which is circumferential all the way around, or it can be saccular, which is just one little spot, like a little sac, almost like a tire, if you've got a little bleb on a tire. And there's also pseudo aneurysms, which is incomplete, and it often involves a clot as well. And whereas a true aneurysm is one that involves all three layers. So remember, on any blood vessel, you have the intima, the media, and the one on the outside, and those three make up the three layers. And if all three layers are pooched out, whatever, then that would be a true aneurysm. But if it's not all three layers, then they'd call it a false aneurysm. So some of the predisposing factors for aneurysms is going to be atherosclerotic vascular disease. Remember, atherosclerosis is where you get a fatty streak on a blood vessel wall. Macrophages and white blood cells come to the area, try to eat it up. It causes foam cells, and then you get a fibrous cap over the top of it. It narrows the diameter, also weakens the wall of the blood vessel. That's mostly what causes it. 20% of aortic aneurysms are associated with familial or genetic diseases, such as Marfan or Ehlers-Danlos disease, Ehlers-Danlos. These are basically where your, you have these collagen and elastin, these different types of proteins in your body, and in Marfan or Ehlers-Danlos syndrome, those are messed up. They're not doing their job, and so it makes the artery not as strong, and so it can bulge. Syphilis is a very rare cause of aortic aneurysms. Tuberculosis is even more rare. Occasionally, very rarely, also you'll have situations of vasculitis causing it. Two worth mentioning are Takayasu's and giant cell arteritis. These are pretty much the same thing, except for Takayasu's happens in younger people. Typically, it's going to be with giant cell, it's going to be typically older people. Takayasu's also is commonly called pulseless disease because you'll find that the pulse on the people in their arms can sometimes go away because of the narrowing of the artery. And then giant cell arteritis, you see very similar to the other one, except for mostly it's older people. You'll have jaw claudication, myalgias, like rhabdomyalgias from the muscles. You have pain. Sometimes it'll give you, make you blind as well. Ocular disturbances. A lot of times it involves the temporal artery. So sometimes also trauma can cause aortic aneurysms as well. So the etiology of this is a cystic medial necrosis is typically what happens in the ascending aorta, but in the rest of the aorta, usually it's atherosclerosis. And normally, when someone has an aorta, they don't know that they have an aorta. It's asymptomatic until it starts encroaching on something. Usually, the way that they find out somebody has an aneurysm earlier. Usually, they find out somebody has an aortic aneurysm by giving them an X-ray. They look at it and they'll see this little bulge in their aorta. And then when it happens, then they need to continue to monitor it with an echocardiograph, CT, or an MRI. And then they need to treat it as well. Usually, that's done with beta blockers, ACE inhibitors, ARBs. If it gets to be above 5.5 centimeters or 6.5 centimeters, then surgical repair needs to be done. But it usually be delayed until it gets to being that big. Aortic arch aneurysms abdominal aortic aneurysms are actually more common than aortic aneurysms above the abdomen, especially in male smokers. And and if it gets to be about 5.5 centimeters, it's indicated for surgery. Typically, the treatment is going to be a graft, but there's actually some endovascular treatments that are available as well now. So now moving on over here to acute aortic syndromes. I know you can't read anything on the board, but I can, so just listen to what I'm saying. Acute aortic syndromes include an aortic rupture, intramural hematoma, penetrating atherosclerotic ulcer, and an aortic dissection. Let's talk about what these are. Aortic rupture, obviously it's where the aortic ruptures. Makes sense. Intramural hematoma. So basically, it occurs with a rupture of the vasa vasorum. Usually, it's in the descending aorta, and the mortality rate with surgery in the hospital is somewhere between 50 and 25%. So not a good deal. So I believe that what this is basically, the person has a hematoma inside of the mural layers in their blood vessel. Vasa vasorum are these little tiny, they're almost like blood vessels within blood vessels. So the aorta is really big and so thick that it needs to have its own blood vessels. So usually one of those little blood vessels ruptures, and then you get a hematoma in there, like a big bulge. And that's what that is. Aortic dissection is when there's a tear in the intima. Remember, there's the three layers, intima media and the outer layer. And the intima in an aortic dissection is where the intima gets ripped away, and then blood starts going behind the intima. So that's decreasing. The blood's not going anywhere, but it's decreasing the circumference or the diameter or whatever of the blood vessel, the amount of blood that can travel through it. Really, really serious condition. Usually it's going to be in the right lateral wall of the aorta. That is where the shear stress is the highest. And there's a way of classifying these aortic dissections. The Stanford and the DeBakey method. Apparently the DeBakey method is older and it's more preferred by older surgeons. Stanford is more simple. Stanford is essentially, it's a type A if it involves the aortic arch, and if it's below the aortic arch, then it's a type B. Easy for Stanford. DeBakey involves, well, if it's a type 1, then it involves, the aorta or the aortic arch, and maybe somewhere else. If it's a type 2, it's just the aortic arch. And if it's a type 3, it's below a certain point. And there's type 3A and there's type 3B. It's kind of confusing. Look it up online if you're interested in it. Anyway, penetrating atherosclerotic ulcer is the other one. That one also makes more pretty sense as to what it is, but it usually happens in mid to lower thoracic. And basically what you have here is you have an atherosclerotic plaque. It gets all ulcerated. Ulcer is like a hole where it kind of gets eaten into it, and it penetrates through and makes an aneurysm. Makes a problem, whatever. Risk factors for the aortic dissection is going to be hypertension. Obviously, if you have really high blood pressure, it's putting a lot of pressure on the intima and increases the likelihood of a tear. Cystic medial necrosis, which is basically on the inside, medial layers there in the vessel. Some of it gets necrosed and dies. And Ehlers-Danlos or Marfan syndrome, we talked about that earlier. Aoritis, which is basically inflammation of the aorta. We'll talk about that a little more later as well. Takayasu's giant cell are forms of aoritis. Congenital cardiac anomalies, especially bicuspid or the aortic valves. Remember, makes sense with the aortic valves because obviously they're the ones going into the aorta from the left ventricle. Also coarctation of the aorta. Coarctation of the aorta is essentially where the aorta comes up like this, and it goes down, and there was this little spot here when you were in your mother's uterus that connected the pulmonary and the aortic circulation, and this was the ductus arteriosus, and that's supposed to close off. And sometimes when that closes off, though, it also closes off little pieces of the aorta and causes coarctation of the aorta. So the aorta was going down fine, all of a sudden it gets pinched down real tight where that, right around the place where that, they call the ligamentum arteriosum when it closes off. That's what they call the ductus arteriosus. It becomes ligamentum arteriosum. So right where that closes off, it becomes coarctation of the aorta. Now that you need to note that this coarctation of the aorta actually occurs after the three main blood vessels coming off of the aortic arch. And so all the head and the arms are all supplied with plenty of blood, but the lower extremities get decreased amount of blood. And usually this shows up somewhere in the teenage years, where a teenager is all of a sudden going to have some problems here. You know, whatever problems would be associated with decreased blood flow to the lower extremities and increase to the upper extremities. You also find the blood is really trying to find ways to go from the aorta to the rest of the body. And so one of the things it does is it actually goes into the, can't remember the name for them, but the blood vessels that go between the ribs. Okay, not coming to me. But anyways, man, I swear. Anyway, I'm not going to worry about it. Basically what happens is the blood vessels, those ones become like engorged, and you start making more of them and everything. And the blood travels through that way to get to the rest of the body through this it's like costo something. Anyway, in those blood vessels, and it actually causes a notching of the ribs because they'll get so big. And so on an X-ray, you will see that the ribs have been kind of notched out by those blood vessels. Some people say it's not very common, but it's something that they talk about. Another thing that can be associated with the risk factor with aortic dissection is actually the third trimester of pregnancy, which makes sense because during the third trimester of pregnancy, women typically have a lot more blood in them to supply blood for the baby, and all that blood would increase hypertension, blood pressure, and could result in some problems. The patient is going to come in and usually present with this feeling of ripping or tearing chest pain. Usually it's going to be a man, and usually the man is going to be 60 or older. And when you check the pulse in his lower extremities, you're going to find that his pulse is decreased. Why is it decreased? Because the aortic dissection is now having blood going into the intima layer, behind the intima layer, and so less blood is going down to the rest of the body. It's kind of almost blocking it off. So you do a chest X-ray on them, and you find a widened mediastinum. Then you follow up with a CT, MRI, echocardiograph. That's very good at diagnosing it. Treatment is going to be a beta blocker. This is actually one of the rare cases where you give treatment before you actually diagnose. Even if you don't know what's happening, so a patient comes in, they have some of the general signs and symptoms, you haven't done the X-rays or anything yet, but you've got a good indication for it, you need to save their life immediately. And so you actually are going to treat before you diagnose, for sure diagnosis. So you're going to give them esmolol. Esmolol is a beta blocker. It has an extremely short half-life of about 9 minutes, and so it's going to wear off quickly. Also nitroprusside. Nitroprusside releases nitric oxide, which causes vasodilation. Beta blocker means that it's going to basically block the effects of beta receptors, which have effects on the heart and on vasculature. This is going to drop the blood pressure. You're trying to get the blood pressure down to 120, less than 120, within 20 minutes. So I mean that's really fast, lowering the blood pressure a lot. They're going to need surgical repair immediately, and there's about 10 to 20% mortality rate in hospitals with this surgery. And of those that survive, usually there's 60% mortality over the next 10 years. So 60% of them die within 10 years. Long term, these people are going to need continue to take beta blockers to decrease their hypertension, and also they're going to need ACE inhibitors and ARBs to also help with their hypertension. Next, we're going to talk a little bit about coarctation of the aorta. Coarctation of the aorta we already described earlier. Remember? I'm not even going to discuss it. We already talked about it. Sorry. Aortitis. We already talked about that as well, which is the Takyasu's or giant cell. And lastly, infective aortitis, which is usually caused by Staphylococcus infections, Streptococcus infections, very, very rarely syphilis. And that's it.